Let's review hemoglobin variants. In hemoglobin S, valine replaces glutamic acid at the 6th position of the beta chain. This single amino acid substitution is responsible for sickle cell disease, where red blood cells deform into sickle shapes under low oxygen conditions. In hemoglobin C, lysine replaces glutamic acid at the same 6th position of the beta chain. This variant leads to the formation of hemoglobin C disease, often associated with target cells and mild hemolytic anemia. Hemoglobin D is commonly seen in East Indian individuals. On alkaline electrophoresis at pH 8.6, hemoglobin D migrates in the same position as hemoglobin S, making further confirmatory testing necessary to distinguish between the two. Hemoglobin E is prevalent among Southeast Asian populations. It also migrates with hemoglobin C and hemoglobin A2 at pH 8.6. Clinically, it is associated with hypochromic and microcytic red blood cells, resembling thalassemia traits. Hemoglobin G is the most common alpha chain variant found in African Americans. On electrophoresis at pH 8.6, it migrates in the same position as hemoglobin S, which can cause diagnostic confusion unless additional tests are performed. In summary, hemoglobin S and C involve point mutations at the same position of the beta chain. Hemoglobins D, E, and G can co-migrate with other variants at alkaline pH, highlighting the need for careful interpretation of electrophoresis results. Hemoglobinopathies are inherited disorders affecting hemoglobin structure or production. Most structural mutations involve the beta chain except for hemoglobin G. Other disorders result from decreased production of alpha or beta chains, known as thalassemias. Hemoglobin S is caused by a mutation in the beta chain. In the heterozygous state, individuals are usually asymptomatic. This is called sickle cell trait. In the homozygous state, it causes sickle cell disease, a severe chronic hemolytic anemia with multiple complications. On a right-stained smear, sickle cells can be seen in sickle cell disease but not in trait. The Sickle Dex test uses sodium dithionite, a reducing agent, to precipitate hemoglobin S, causing turbidity. Confirmation requires hemoglobin electrophoresis. On cellulose acetate at alkaline pH 8.6, hemoglobin S migrates with hemoglobins D, G, and Lepore. On citrate agar at acidic pH 6.2, hemoglobin S separates from these variants, allowing accurate identification. Hemoglobin C results from another beta chain mutation. Heterozygotes are asymptomatic. Homozygotes usually have a mild chronic anemia. On blood smears, you may see hemoglobin C crystals, which are bar-shaped, along with target cells. In SC disease, the crystals are distinctive, described as a hand-in-glove or Washington Monument appearance. Confirmation also requires electrophoresis. On cellulose acetate, hemoglobin C migrates with hemoglobin A2, E, O, and G, Philadelphia. On citrate agar, hemoglobin C separates clearly from these other variants. Beta thalassemia is due to decreased or absent production of beta chains. This leads to a microcytic hypochromic anemia. Hemoglobin electrophoresis shows increased hemoglobin A2 and hemoglobin F, decreased or absent hemoglobin A. Alpha thalassemia is due to deletions of alpha globin genes. With one gene deleted, the individual is a silent carrier, usually with a normal CBC. With two genes deleted, there is a mild microcytic hypochromic anemia. With three genes deleted, the condition is called hemoglobin H disease, which causes significant clinical disease. Let's review anemia. By definition, anemia is a reduction in hemoglobin and hematocrit. To classify anemia, we look at the mean corpuscular volume, or MCV, which tells us if the red cells are small, normal-sized, or large. When the MCV is low, we call the anemia microcytic. The two main categories are seen in problems with heme or in globin synthesis. First one is problem with heme synthesis, as seen in iron deficiency anemia, the most common cause of microcytic anemia worldwide. Sideroblastic anemia, where iron cannot be incorporated into hemoglobin properly. And anemia of chronic disease or inflammation, which interferes with iron utilization. The next one is problem with globin synthesis, as seen in Thalassemias, inherited disorders of alpha or beta chain production, and hemoglobin E, a structural variant more common in Southeast Asia. When the MCV is normal, the anemia is called normocytic. There are several causes. The first one is antibody destruction, which includes hemolytic disease of the newborn, hemolytic transfusion reaction, and autoimmune hemolytic anemia. The next one is red blood cell membrane defects, which includes hereditary spherocytosis, hereditary elliptocytosis, and paroxysmal nocturnal hemoglobinuria, or PNH. The next one is enzyme deficiencies, which includes glucose 6-phosphate dehydrogenase deficiency and pyruvate kinase deficiency. The next one is decreased production or increased loss, which includes aplastic anemia, chronic renal disease, acute blood loss, and bone marrow infiltration by malignancy. The next one is hemoglobinopathies, which includes structural variants such as hemoglobin S and hemoglobin C. There are other external factors such as antagonistic plasma factors and physical trauma, such as microangiopathic hemolysis in prosthetic heart valves. When the MCV is high, the anemia is macrocytic. These are further divided into megaloblastic anemia and non-megaloblastic macrocytosis. Megaloblastic anemia, which is caused by impaired DNA synthesis. This can be seen in cases of vitamin B12 deficiency, folate deficiency, myeloproliferative neoplasms, and myelodysplastic syndromes. Non-megaloblastic macrocytosis is often due to liver disease or chronic alcoholism, where the red cells are large but not truly megaloblastic. In summary, in microcytic anemia, think problems with iron or globin synthesis. In normocytic anemia, think destruction, membrane or enzyme defects, decreased production, hemoglobinopathies, or trauma. In macrocytic anemia, think impaired DNA synthesis, megaloblastic, or liver alcohol-related causes, non-megaloblastic. Now let's review special tests in hematology, which are used for specific diagnostic purposes beyond routine laboratory studies. The FLAIR test, using fluorescent erythrolysin, detects the absence of GPI anchor proteins such as CD55 and CD59 on red cells and granulocytes. It is used to diagnose paroxysmal nocturnal hemoglobinuria, or PNH. Compared to other tests, it is considered more specific and sensitive. Flow cytometry also looks for deficiency of CD55 and CD59 on red cells and granulocytes. It is another way to diagnose PNH, although it is less sensitive than the FLAER test. In Heinz body preparation, supravital stain is used. This test measures the effect of oxidizing agents on hemoglobin, leading to the formation of precipitated globin chains called Heinz bodies. It is useful in G6PD deficiency, unstable hemoglobins, and hemoglobin H disease. Formation of Heinz bodies is often triggered by oxidants such as antimalarial drugs, fava beans, or sulfa drugs. The sickle cell screen test detects the reduced solubility of deoxygenated hemoglobin S. It is used to screen for hemoglobin S disorders, particularly sickle cell disease. The principle involves using a reducing agent, such as sodium dithionite, to precipitate hemoglobin S. The Kleihauer-Betke acid elution test takes advantage of the resistance of fetal hemoglobin to acid elution. It is used to detect fetal maternal hemorrhage and to confirm hereditary persistence of fetal hemoglobin. In this test, cells containing fetal hemoglobin stain pink, while normal adult cells appear as ghost cells. Hemoglobin electrophoresis separates hemoglobins based on their migration at different pH levels. It is indicated for suspected hemoglobinopathies. It may be performed at both alkaline pH and acidic pH, since some variants migrate together in one system and must be distinguished using the other. The cold agglutinin titer test detects the presence of cold autoantibodies, specifically IgM antibodies. It is used to diagnose cold autoimmune hemolytic anemia. The antibodies detected typically have anti-I specificity. The Donath-Landsteiner test identifies the presence of a biphasic hemolysin antibody, known as the Donath-Landsteiner antibody. It is diagnostic for paroxysmal cold hemoglobinuria. The antibody is usually an IgG with anti-P specificity. In summary, FLAER and flow cytometry. Diagnose paroxysmal nocturnal hemoglobinuria. Heinz body prep detects G6PD deficiency, unstable hemoglobins, and hemoglobin H disease. Sickle cell screen screens for hemoglobin S using solubility reduction. Kleihauer-Betke identifies fetal hemoglobin in maternal circulation. Hemoglobin electrophoresis identifies hemoglobin variants. Cold agglutinin titer diagnoses cold autoimmune hemolytic anemia. Donath-Landsteiner test confirms paroxysmal cold hemoglobinuria. Let's walk through erythrocytoses. Erythrocytosis means an increased number of red blood cells, reflected in an elevated hemoglobin and hematocrit. Relative erythrocytosis occurs when there is a decrease in plasma volume, not an actual increase in red cells. This can happen in situations such as burns, dehydration, or Gay-Bach syndrome. Absolute erythrocytosis, on the other hand, involves a true increase in red cell mass. It can be further divided into primary and secondary types. In primary absolute erythrocytosis, erythropoietin levels are decreased. Oxygen saturation remains normal. The classic example is polycythemia vera, a myeloproliferative disorder in which the bone marrow produces too many red cells. In secondary absolute erythrocytosis, erythropoietin levels are increased. Oxygen saturation is decreased. It is commonly seen in chronic obstructive lung disease and in individuals with hemoglobins that have abnormally high oxygen affinity, which limit oxygen delivery to tissues.